Hello and welcome back. In Chapter 9, we're discussing the treatment of comorbid disorders. So, comorbidity is substance use disorders and other mental disorders in extensive that are highly correlated. So, when we talk about correlated, we're talking about disorders that can be related to each other, that have a high probability of if you have one, you have the other, right? A lot of times with this addictions treatment or whatnot, you're gonna find that substance abuse disorders can be influenced by other mental health disorders, or mental health disorders can be influenced by substance abuse disorders. In the preceding chapters, we discussed assessment and how we would assess for those things. One thing we would want to assess is to see if there's an influence on those comorbid disorders. So co-occurring disorders are related to the cost included increase in healthcare and hospitalization costs, less satisfying family relationships, or poor treatment outcomes. So with the fifth edition of the DSM-5, the previous terms of co-occurring, which has been replaced to the earlier term dual diagnosis, has itself been replaced by the term comorbid. Comorbid refers to disorders with client suffers from a psychiatric disorder along with a current SUD disorder. So prior to 1984, there were few, if any, treatments available to serve those clients who entered the mental health system presenting with SUD issues. So dual diagnosis treatment programs had their beginning in 1984 in a New York State outpatient psychiatric facility. So the prevalence of comorbidity. For a client to present with a single SUD without a coexisting SUD or without a coexisting psychiatric disorder would be the exception rather than the rule. So 25 to 30% of alcoholics experience depression and anxiety, respectively, while approximately 25% of all suicides are committed by individuals with chronic alcohol use disorders. In regards to adolescents, 37% of who used illicit drugs in 2016 were diagnosed with a major depressive disorder, compared to those that did not at 13.4%. For those adolescents who had a co-occurring mental health disorder and a SUD disorder in the past year, 71.9% received specialized treatment for substance use disorders or some form of mental health treatment. The prevalence of any lifetime SUD was 37% for schizophrenia. 35% of schizotypal disorder is 28% of other psychosis, 32% from bipolar disorder, 25% for depression, 25% for anxiety, 11% for OCD, 17% for post-traumatic stress disorder, and 46% for personality disorders. So let's talk about assessment and treating SUDs. So professionals need to pay attention to the client predisposing factors such as the parental history of alcohol use, risk taking, and the diagnosis of ADHD. In addition, factors such as history of juvenile justice problems or poor coping skills with a positive factors such as willingness to cooperate with professionals and good physical health needs to be considered for treatment planning. So the American Psychological Association has recognized the need for additional patient assessment measures to assist with treatment planning. Therefore, there have been developed three level one cross-cutting symptom measures. They caution that these should not be used as the only basis of making clinical diagnosis. The severity of substance use in psychiatric disorders is an important consideration in treatment planning. However, the focus of treatment planning should be the immediate assessment, which is any emergency medical or psychiatric symptoms, and those should include an extensive history of related to these factors. Recently, in the agency that I consult with or whatnot, there has been clients who have been denied services because their treatment plan has not been addressing their ASAM dimensions. Especially, we're talking about Dimension 3, which discusses cognitive and behavioral issues or whatnot. If there are issues that are presented in that dimension, and there's no mention of those in the treatment plan, or there's not the treatment plan doesn't address them, Medicaid and other insurance companies and whatnot have been reluctant to actually pay for services because they want to make sure that the treatment plan is assessing and dealing with any emergency or psychiatric symptoms. So cultural issues related to assessment. Especially during assessment, it is important that counselors understand the background of the client, communications, healing, and understanding of both mental disorders and substance use disorders. Culturally effective counselors study that interpersonal relationships and our interactions and expectations of family play a huge role in treatment. So rates of comorbidity vary significantly among differing racial and ethnic groups. More whites receive comorbid diagnosis than did racial or ethnic minorities. For example, only 5.4% of blacks, 5.8% of Latinos, and 2.1% of Asian receive comorbid diagnosis. It is strongly recommended that cultural sensitivity methods be used with clients with comorbid diagnoses. So treatment and care needs. The best practices should be present in both residential and outpatient programs. Screening, assessment, referral, physical and mental health consulting, the presence of prescribing on-site psychiatrists, availability of medication and medication oversight are important to assess for. Psychoeducational classes that focus on mental health and substance use disorders, including relapse prevention, on-site mental health and SUD groups, off-site dual recovery mutual self-help groups tailored to the special needs of a variety of people, and family education and treatment. Those providing counseling services to clients with comorbidity must apply specialized techniques to deal with increased probability of high-risk behaviors like sharing needles, unprotected sex, and prostitution. The disease concept model. For those counselors who are comfortable working from disease concept model with a comorbid client, using 12-step groups as a treatment adjunct makes sense. Debriefing clients after 12-step meetings may be the turning point in recovery. Remember, the 12 steps is a model that is utilized with self-help groups or whatnot to actually help clients go through steps of recovery, and it's really organized, and it can be a really effective way of helping someone actually manage their disease over a lifetime. Alternative models. SUDs are not all the same level of severity, and some SUD counselors believe that the severity falls with the continuum, with sporadic detrimental use on one end and relentless addiction on the other end. Alternative models. Merlet, Bayer, and Quigley proposed a self-efficacy model that matches treatment focus with the level of SUD severity that ranges from pre-use to severe addiction. The authors describe 5 types of self-efficacy that assist with SUD treatment: resistance self-efficacy, human reduction self-efficacy, action self-efficacy, coping self-efficacy, and recovery self-efficacy. And remember, self-efficacy is going to be how efficacious you feel you are at a specific task, right? So, for instance, at a point in my life, I didn't feel very efficacious cooking, right? So, guess what I would do? I would probably eat out more than I would cook because I didn't feel efficacious at actually cooking the meal or whatnot. If you don't feel efficacious at doing something, you're probably not going to put more effort in or attempts to actually do so. Alternative models. The solution focused therapy model. A solution focused approach emphasizes client successes, strengths, and resources rather than their illness or failures. It stresses the importance of accepting working within the client's frame of reference, assuming a theoretical or non normative reference, and a client determined posture towards alcohol problems. And solution focus can be a best practice, especially those with severe mental health disorders, because again, it's something that you giving the client strength and tools in that moment that are going to be more short term. Because again, if I have a severe substance abuse disorder, I'm going to need some short term or some quick therapeutic tools to actually keep me safe and to get me back into stabilization. Cognitive behavioral therapy is a recommended component of treatment for comorbid disorders because of the wide variety of human mental health and substance use problems that can be targeted. And we talk about cognitive behavioral therapy, we're talking about those belief systems. We're talking about that core belief, those values, morals, and experiences that you have. You talk about those intermediate beliefs, those rules and expectations you have for everyday events, right? Which leads into your automatic forms of thinking, right? Automatic forms of negative thinking. Remember, there said to be 16 to 18 different types of automatic negative thought processes, right? Helping the client understand those things and become aware and conscious of those things so they can actually reframe them can help you in a behavioral model, especially with comorbid disorders. Technology. The use of technologies for both mental illness and SUD is becoming more popular. and has demonstrated some positive outcomes. When an SUD or comorbid client questions a particular counselor or staff member about whether the counselor is in recovery for SUD, especially in front of other clients, this has the potential to create a they situation if not handled effectively. Again, you don't have to. Empathy is one of the cornerstones of what we do in counseling. You don't have to have experience what the client has experienced to provide care for them, but the ability to understand a feeling or whatnot can create a level of connection, right? So again, being having prior use is not a prerequisite to being a substance abuse counselor. A multidisciplinary treatment team are often beneficial to a client's recovery because each team member offers a unique perspective to diagnosis, right? They typically include mental health counselors, SUD treatment counselors, case managers, nursing staff, and psychiatric consultants. For programs that are CARF accredited or Joint Commission accredited or have a certain types of accreditation and whatnot, you have a standard to have a multidisciplinary team, a team that actually consults on a weekly basis about the client's care and their appropriate placement in the certain specific level of care. A non-pathological method of assessment would involve helping clients identify their treatment issues as a part of their diagnostic process. Being specific, behavioral, and measurable, and identifying issues can serve as a baseline or a pretest, which can help in evaluating treatment progress. Treatment planning is also the portion of the therapeutic process in which we can help the client select specific counseling strategies and techniques, as well as setting timelines. Again, we kind of ended with treatment planning, but treatment planning is the most vital thing that we do because effective treatment planning and individualized treatment planning is really important, guys. Because again, we need to make sure that our treatment plan is addressing the client's elements, and the client's playing a huge role in selecting their goals, selecting their objectives or whatnot. I like to tell my clinicians to utilize quotation marks when they actually identify a goal, so that that's coming from the client. Clients tend to actually be more engaged in activities that they are a part of, right? So you want to make sure they're measurable. We want to make sure that they're addressing the client's major symptoms or whatnot, and we want to make sure they're actually feasible for the client. These are things that tools the client can actually use to actually and be able to follow, right? And treatment planning, and make sure that we follow those treatment plans so our clients are not in treatment for prolonged periods of time because we're veering away from the treatment plan. Our treatment plan is a set of directions for us to actually that we're going to engage with the client has agreed upon and whatnot. And there's a plan that both people are part of, and we have to make sure that we are collaborating together and using that treatment plan throughout the client's treatment process because it gives us our sense of direction.